Hi, everybody. Glad to chat with everybody today. We're just going to talk briefly about Aliqopa or copanlisib for follicular lymphoma. It's been approved for third-line use in the follicular arena. Next slide, please. Just a reminder, follicular lymphoma is about 20% of the non-Hodgkin's lymphoma subtypes. So we do see a lot of patients in the clinic with this type of disease. It's considered an indolent lymphoma, but generally patients are still going to suffer and ultimately die from this cancer, even though it's considered a more indolent type of lymphoma. Next slide, please. The NCCN guidelines, this is just a quick snapshot of the second and subsequent line therapies that are available for FL. First line, we generally treat our patients in the clinic with rituximab-based Rituxan and chemotherapy-based regimens. R-CHOP, R-CVP, R-bendamustine are typically used, and most of the patients have seen that therapy first or second line. Then, as you can see from the guidelines, the other recommended regimens that are now in place as far as NCCN is concerned, the immunoradiotherapy, Egerton, is an option for patients. And now there are two options, idelalisib or Zidelig and copanlisib or Aliqopa. The brand names are easy to say, so that's how I'm going to refer to them going forward. These are both available products, one being oral and the other product in intravenous formulation. Next slide, please. Both of these drugs, we're going to be specifically focusing on Aliqopa. But both of these drugs are PI3K inhibitors. They inhibit PI3K in B cells. The Aliqopa is actually the first product that's been approved that's an inhibitor of both the alpha and delta formulations of PI3K. Zidelig is more specific to the delta isoform. So therefore, they may that does tend to lead to different side effect profiles. Again, PI3K plays a significant role in receptor signaling, and therefore is a very active pathway in these type of lymphomas. Next slide, please. Some of the safety things to be aware of with Aliqopa. In the clinical trial, hyperglycemia and hypertension were things that would maybe a little bit more atypical that we would need to watch for in patients. Your blood glucose as well as blood pressure need to be checked prior to each dose in the clinic. Other safety signals are neutropenia and non-infectious pneumonitis. Obviously, we have to warn patients who are receiving this medication of contraceptive precautions and advise against breastfeeding during the first treatment and for at least 1 month after the last dose. Because the drug is metabolized through CYP3A, we have to be careful with our CYP3A inducers and inhibitors as far as monitoring for increased side effects or needing a dose reduction when starting. Next slide, please. Generally, as far as GI toxicities, Zidelig does have a lot of warnings related to diarrhea, colitis, GI toxicities, and significantly, elevated LFTs and hepatotoxicity concerns. So Aliqopa is a little bit different in the way the mechanism occurs, and therefore there's a less tendency to have GI toxicities, which is a thing to consider based on your patient's profile and performance status. Next slide, please. Some pharmacy considerations when using Aliqopa. Again, there's really no need to dose adjust for mild renal or hepatic insufficiency. There are certain dose adjustments that we'll review in a further slide based on other toxicities. There does need to be a dose reduction to 45 milligrams if you're using a CYP3A inhibitor. And as far as administration, there's really no pre-medications required. It is considered obviously monotherapy, and since it's a tyrosine kinase inhibitor, it's not really technically chemotherapy. Refrigeration after reconstitution is required. Next slide. The drug was approved based on the Cronus-1 study, which is a phase 2 clinical trial. It was used as monotherapy in 142 patients, and out of those 142 patients, 104 were patients with relapsed follicular lymphoma. And most patients were heavily pretreated. Again, this is approved for third line. So after at least 2 prior treatments, patients were eligible for this study. And they also had obviously previously received Rituxan and an alkylating agent. So the dose was 60 milligrams administered. There were a few patients that received weight-based dosing, but the majority of patients received 60 milligrams, and it's a 1-hour infusion on days 1, 8, and 15 of a 28-day cycle. And the treatment in the study was continued into disease progression or a toxicity. The primary endpoints of the study were overall response rate, and the secondary endpoints were median duration of response, PFS, overall survival, quality of life, and safety. Next slide, please. You can take a look at the baseline characteristics of the patients in this study. Most of these patients were pretty typical, mostly Caucasian, a little bit more male than female. But one note to take note of is that most of the patients were performance status 0 to 1. So even though these patients were pretty heavily pretreated, had received 2 or 3 lines of therapy, as you can see, their performance status was still very good. You can see what regimens the patients had previously received. Again, the majority of these patients are going to see Rituxan or another CD20 antibody, plus an alkylating agent and chemotherapy. Next slide, please. This is just a quick snapshot of the efficacy from Cronus-1. So again, even though these patients were heavily pretreated, the overall response rate for patients was 59%, which is very good. There were 14% or 15 patients in the study that had CRs, and 44% of patients had partial responses. Next slide, please. The median duration of response, again, was 12.2 months, which you can see was extended out in some patients to almost 2 years. So a very good duration of response on Aliqopa. And it also has a very rapid onset of action. Generally, patients see, or physicians will see a response in their patients within 1 to 2 months. Next slide, please. Just a reminder on the dosing administration. So it is given IV on 3 weeks out of 4 weeks, once a month. 60 milligrams, 1-hour infusion. So it's pretty straightforward in the clinic, in the pharmacy, and for nursing and pharmacy personnel to prepare and administer. Next slide, please. This is a little bit a busy slide. The next 2 slides is some dose modifications to consider. Again, for the hyperglycemia and hypertension, you need to check levels prior to each dose, and then base your dose adjustments on the results of those labs. So based on a pre-dose fasting blood glucose of 160 milligrams or more, or random fasting, non-fasting blood glucose of 200 or more, you would want to withhold the dose and make sure the blood sugar gets under control before administering that next dose to the patient. Obviously, if the pre-dose or post-dose blood glucose is 500 or more, that's a significant issue. You would want to obviously look at dose reducing from 60 to 45 milligrams and maintain at that dose. And then obviously keep assessing the blood sugar as the patient continues on therapy if there's possible reasons to dose reduce further from 45 to 30 milligrams based on their blood sugars. Hypertension, same issue, monitor pre-dose, and then based on what is listed here, withhold the dose or decide to dose reduce based on the blood pressure effect. We did have one patient in our clinic here at NYOH. Actually, she's been on the drug for about 6 months, having a good response. We did have to adjust her dose from 60 to 45 milligrams based on an initial issue with hypertension with her first infusion. She's done very well since, had to increase her lisinopril dose from 2.5 to 5 milligrams, but other than that, she's been tolerating therapy very well and continuing on at a dose of 45 milligrams. Next slide, please. These are some other dose modifications based on the other toxicities listed. Infections. There is somewhat of a risk in this patient population and with this drug and the way its mechanism of action occurs to have a risk for PCP. Well, it used to be PCP. Now it's PJP. But you would need to take a look at patients, and if any type of infection is potentially brewing, you may need to consider medicating with Bactrim on a prophylactic basis to continue with the patient's Aliqopa therapy. Non-infectious pneumonitis, again, withhold if you have any suspicion that there is pneumonitis going on. Neutropenia based on blood counts, obviously maintaining the dose if possible and monitoring for the ANC. Severe skin reactions, thrombocytopenia, and other serious non-life-threatening toxicities would hold therapy and assess before continuing on. So just in summary, the efficacy of Aliqopa was evaluated in a single-arm multi-center phase 2 study called Kronos-1. 142 patients were enrolled, and of those, 104 patients had follicular lymphoma and had received at least 2 lines of prior therapy. The overall response rate was 59%, with a complete response rate of 14%, a partial response rate of 44%, and 12.2 months of median duration of response, which is very good for patients on 3rd or 4th line treatment. It is a 1-hour infusion, so again, very simple to administer in the clinic, and again, no routine pre-medications required. And it is obviously, as we saw on NCCN, it is recommended as a Category 2 option for follicular lymphoma patients in the 3rd line. Next slide. Aliqopa and Bayer has a very good patient resource for patients on Aliqopa therapy. So there are patient coverage benefits, obviously insurance benefit verifications, prior authorizations. They will help if you have a claim in the appeal process, and other ways to help patients get coverage to receive the medication. The Bayer Patient Assistance Program can certainly help our folks reach out to them quite frequently for Aliqopa and other medications, and often receive assistance in helping patients get the medication. There is a $0 copay program for patients that have commercial insurance, and then for those patients who are government or Medicare, they will assist in referring you to foundations when all possible to help patients afford the medication. So you can see the contact information there on the right to access the Aliqopa resource connections. Next slide, please. So thank you for listening to the short presentation on Aliqopa and follicular lymphoma today. If there are any questions or comments, otherwise, thank you.
Nancy?
Hello? Yes?
Yeah, Nancy, I know you've got some experience with the product with several patients. Any, I know we're tight for time, but any quick pearls to help out practices that may be starting their first patient or maybe on the first dose with a patient? Anything you want to share from a pharmacy or an operations or a clinical perspective?
Yeah, I think, one thing that we came across, our standard medication, pre-medications, a lot of them are templated out in our electronic medical record. And obviously with this medication, with a tendency to potentially cause hyperglycemia issues, you want to be careful that the patient is not receiving anything that might also cause elevated blood sugars. We had a patient that had received a dose of Decadron prior to their first infusion. Didn't cause any problems, but in retrospect, we realized that that should not have been done. So just make sure you're very aware of checking the blood sugar and blood pressure prior to each dose, and have the nursing staff as well as pharmacy aware that they really need to be looking at that prior to each dose and assessing for that. Those, I think, would be really the key things. And once the patient's on therapy, both of our patients have done very, very well. As I said, the one lady is on therapy. She's starting cycle 4 at a reduced dose of 45 milligrams. Our second patient actually had a partial response, and he elected to actually stop therapy. He's pursuing a clinical trial at Dana-Farber as another alternative. However, he is also has stable disease. So in both of our patients, the drug was very well tolerated, and both patients had very good responses.
Thank you, Nancy.